This is an overview of Salter-Harris fractures. Salter-Harris fractures is really just terminology used when discussing fractures that involve the growth plate of long bones. As you might recall, the long part, the shaft of the bone is called the diaphysis. The part of the bone that's proximal to the growth plate is called the metaphysis. This represents the growth plate, and then distal to the growth plate is an area called the epiphysis. So as you can see here, a Salter 1 fracture goes directly through the growth plate. This would be an example of a non-displaced Salter 1 fracture. But you could also imagine that this epiphysis could be displaced, and so you can have a displaced type as well. Type 2 goes through the growth plate and then proximally through the metaphysis. Type 3 goes through the growth plate distally through the epiphysis. Type 4 involves both the metaphysis, the growth plate, and the epiphysis. And lastly, Type 5 is similar to the Type 1, except that it generally represents a crush injury, such that the forces occurred along the long axis of the bone. So for example, here's a single view of an ankle. Can you identify what type of fracture this child has? Pause now if you don't want to hear the answer. So this would best represent a fracture that goes through the growth plate and then through the epiphysis. So that's a Salter-Harris 3 fracture. You would expect that this child would be particularly tender in this area over the growth plate. This child was noted to have pain and swelling on this part of his ankle, right here. Take a look at this x-ray. Does it represent a fracture? If so, what type? Pause if you don't want to hear the answer. The point of this x-ray is to demonstrate the importance of the clinical exam. So if there is point tenderness directly over the growth plate, that would yield a high suspicion for a fracture. What type of fracture could be represented by a normal appearing x-ray? Well, a fracture that goes directly through the growth plate. So a non-displaced Salter 1 fracture really does not have any radiographic evidence. If it was displaced, it would be obvious, but here less so. So we would treat this conservatively as though it were a fracture, bring them back in approximately a week's time, repeat x-rays. If there was indeed a fracture, the child would still have pain, and there would likely be some evidence of healing bone or callus formation.